We are broadcasting live from Children's Hospital of Wisconsin. My name is Corey. I work on the social media team, and today I'm joined by Dr. Michael Kelly. He is the director of our cancer program here in our MACFUN Center, where we care for children with cancer and blood disorders. And today is the beginning of Childhood Cancer Awareness Month, and during this very special live broadcast, we're going to be talking about the care and treatment of children diagnosed with cancer and the search for a cure. And we'd love to hear from you. So if you have questions for Dr. Kelly, or if you'd like to join this conversation, please go ahead and post your questions in the comments section of this video, and we will try to answer as many as we can throughout our live broadcast. And for those of you tuning in right now, please click the like button and let us know you're watching. We really appreciate your feedback. So let's get started. Dr. Kelly, to begin with, can you just describe your role here at Children's Hospital of Wisconsin?
Yes, I can. Thanks, Corey, for having me.
Sure.
And actually run the clinical trials unit in the cancer program as well.
Okay. I thought a great way to begin this conversation would be just to get a better understanding of what cancer is. So when a child has a cancer diagnosis, what is actually going on in that child's body?
That's a really good question, Corey. I mean, and it's a question that we get many times from parents is why did my child get cancer? And really, people need to understand that there are cells every day that are being produced in your body that are abnormal and have the chance of being cancerous. And our bodies actually have really good mechanisms to identify those abnormal cells and clear those abnormal cells before they really have a chance to develop cancer. And it's only when the cell has an ability to escape those surveillance mechanisms do we see development of cancer. And depending upon where the cell is and the type of cell, we can actually see different types of cancers.
And so cancer is not just one thing. It could be a lot of things. Is that right?
Absolutely. And that's the other big misunderstanding is when we talk about pediatric cancers, people think, or pediatric cancer, they think of it in singular terms. And in reality, there's over 150 different subtypes of pediatric cancer and 16 to 20 major subtypes of pediatric cancer.
So you described some of these cells as being abnormal. What is the cause of that? I mean, why are some cells abnormal and some cells normal? What's going on there?
Really, again, another really good question. And again, I think that the answer to that is both a combination of environment as well as genetics. Okay. And what I can tell you is that in adult cancers or in adult patients that develop cancers, the types of cancers that they develop really have environmental causes. So for instance, smoking leads to lung cancer, sun exposure leads to skin cancer, eating certain types of foods increases your risk for certain types of gastrointestinal cancers. In kids, it's very different. The environment does not play as strong a role, at least that we can determine, but the genetics are a much bigger driver. And for reasons that we truly don't understand, is that there seems to be different types of genetic changes that occur in kids with cancer and different pediatric cancers than those that occur in adults.
So you mentioned some of the cancers that are impacting the adult population, and when we look at the pediatric or child population, are there certain types of cancers that are more common than others in the pediatric field?
Absolutely, and again, very different than the adult or incidence of cancer in adults. So the two most common types of cancer in kids are actually leukemias and brain tumors, and in adults they're actually those are very small numbers of patients compared to other types of cancers.
Okay. Looks like we have a question here that Damien had asked through Facebook, and Damien asked, I'm a 25-year-old survivor after being treated twice at Children's Hospital of Wisconsin. What are we doing for quality of life post-survivorship, especially considering 95% of childhood survivors will have lifelong side effects? And he goes on to say, I will undergo my 34th surgery next month since my diagnosis in 1991.
So, Damien, that's a fantastic question, and I really think it highlights one of the biggest challenges that we have as pediatric oncologists and people that take care of kids with cancer, is that survivors of pediatric cancer grow up to be adults. And we have done a very good job of improving overall survival of kids with cancer. And in overall, about 80 to 85% of all patients that are diagnosed with pediatric cancer will survive. When you think about that, that means that there's a growing population in the state of Wisconsin and in the nation of pediatric cancer survivors. And what we found by following these patients is that these patients actually have significant problems later in life that really impact their quality of life.
Now, those issues that came about because they had cancer as a child, it's not cancer that they're getting later on in life, but they're related to the fact that they were diagnosed?
Again, it's both, actually.
Yeah. Okay.
So it's interesting when kids are diagnosed with cancer, they're actively growing.
Yeah.
So unlike adults where we're done growing, kids continue to grow. So cancer and cancer therapies really influence that process. So cancer therapies can actually increase your risk for additional cancers later on in life, or even common cancers that occur in adult life can occur much earlier. But what Damien is getting at is that what we really need to do is develop a system in which we can support our cancer survivors in a very uniform fashion and be able to tailor their therapies and their support based upon their needs.
Great. And for those of you watching live on Facebook right now, please go ahead and post your questions in the comment section of this video, and we'd love to get your questions throughout our live broadcast. Another question here. How do cancers spread throughout the body? What is going on? Why do they spread, or why do some spread, I guess?
Really good question, and what you're getting at is not all cancers spread.
Okay.
And the reality is that depending upon the type of cancer that develops, that cancer can be in one spot, or localized is the term that we use, or can spread to very different areas of the body, and that's called metastasis. And what we know in studying cells that either are localized or have metastasized is that they actually have very different characteristics. So cells can start out, or tumors and cancers can start out localized, but they go through further changes that allow them to actually spread to different areas of the body. And we're beginning to understand the mechanisms at a molecular and a genetic level to understand those events and what causes that.
And I would imagine when the cancer starts to spread, the treatment, it gets more challenging, right? And the outcomes maybe are trickier.
It is, and again, a rule of thumb is that localized cancers are in general much more successfully treated.
Okay.
Cancers that have metastasized are much more difficult and require much different and much more aggressive therapy.
Okay. Curious, how have we advanced in medicine in the care for children with cancer, like over the last 10, 15, or 20 years? Have there been advances in the treatments and care of children with cancer?
Absolutely.
Yeah.
And I think that's a really critical point for our audience to realize is that since 1970, we've improved overall survival of pediatric cancer patients from the 30% mark to over 80%, which is phenomenal. But as Damien's question points out, there are significant consequences to that. So cures come with a consequence. And most of our cures or advances in cures have come through more aggressive therapies, and as a result, more problems later on in life. The biggest change, and we're still sort of in this, is understanding cancers at a genetic level. And the genetics of cancers really kind of hold the cue or clue as to a more targeted and more successful therapies. So the application of our understanding over the next 10, 15 years, our hope will increase cure rates, but also decrease the long-term side effects that we see pretty commonly in our survivors currently.
So let me understand the genetic side of this a little bit better. So the genetic makeup of a cancerous cell is unique, is that correct? and the genetic makeup of a person is unique. And so how do you apply genetics or genetic medicine in looking at researching cancer or identifying potential treatment options?
So another really good question, and the answer is we're still learning how to do that. But the reality is that cancer cells arise from the person in which the cancer is in. So there's a lot of shared genetic material that's identical between a cancer cell and a normal cell in that person. But there are actually substantive differences between the cancer cell and normal cells. And it's those differences that we've really focused on and many times provide cues and clues as to what changes are really driving that cancer to grow and keep growing.
Now, you mentioned earlier your role in research. Can you talk a little bit about just the impact that research has in the work you do and the work we do here in our Mac Fun Center?
Absolutely, and I think that one of the biggest differences between our center and many centers around is that we have an integrated clinical care and clinical research program. And what that means is that almost all of our patients are enrolled on clinical trials, and through that we have a greater understanding of how our treatments work, what are the characteristics of families that or patients that have successful treatments and those that do not. But we also utilize our clinical research program in order to collect specimens that we can share with researchers across both at our institution and across the nation.
So the work you and our team is doing here doesn't just benefit our patients, but it benefits everybody.
Absolutely, right? and again, we participate in a very large children's oncology group consortium, which is about 250 institutions that are across North America and international. And through that collaboration, we're actually advancing treatment options for our patients with different types of cancer, but equally important, we're gaining much better understanding of the biology of different types of cancers in order to tailor therapies to improve survival and reduce toxicity.
So is the time that we're living in right now, with all the advances in genetic medicine, all the research that's been put into cancer, how do you feel about things? Like, are you optimistic? How close are we to new treatments?
Well, we have new treatments every day.
Really?
We're part of what's called an early phase clinical trial consortium, and actually many different consortium. And what we're doing in that scenario is actually testing new therapies. So, for instance, right now we have over 40 new therapies that are being tested for the first time in kids with cancer. So that's a very good example of how we're implementing what's being found in the lab and really applying that to kids and young adults with cancer.
Wow. Looks like we have some questions from our live audience.
Yeah, so Martha had asked a question in regards to the pediatric funding for cancer. How important is federal and private funding to research a pediatric cancer?
Absolutely, great question, and both are critically important. The problem right now is that federal funding for research is down across the board, and that disproportionately affects childhood cancer research because a majority of childhood cancer research is actually funded through the federal government. So since the mid-2000s, 2005 to 2015, there was actually a 30% decrease in federal funding. In order to continue to offer our patients new opportunities and new therapies, we rely more and more on philanthropic support, both at our community and at a national level.
And so, for example, here in the Milwaukee community, are there certain organizations that have really helped us along the way?
Yes, absolutely fantastic community support for our cancer program. Some of our biggest supporters are the MAC Fund, or Midwest Athletes Against Childhood Cancer, who have funded our program for over 30 years. Northwestern Mutual has been a big sponsor over the course of the last several years and has been instrumental in helping us develop the new Mac Fun Center and Day Hospital. But beyond those, there are smaller organizations that really are important for us to meet our mission and for us to be able to offer kids with cancer the newest therapies possible.
Good. More interested now a little bit more about the clinical trial side of things. When we say it's like a phase 1 or a phase 2 or a phase 3 clinical trial, what do those designations or phases mean?
Really good question, and this is a question that we get a lot from our patients and families. So most times when patients come into our center with newly diagnosed cancer, we enroll them on a phase 3 trial. And what that means is that we're comparing one treatment to another. Both have been shown to be helpful, and what we're really trying to determine is which one is the best, which one has better cancer control, and which one has fewer toxicities or problems. In a phase 1 trial, phase 1 trials are really looking at safety of new agents. So those are the true first-in-children type of trials. And phase 2 is in between. We're taking those we're taking those new agents that have been shown to be safe, and then actually asking the question, in certain types of diseases, do we see an effect?
Okay. And for everybody watching live right now on Facebook, please go ahead and click the like button and let us know you're watching. Again, we want to hear your feedback. Looks like we have some more questions from our live audience.
Yeah, so one of our fans had just specifically asked about a certain type of cancer and the chances of survival in DIPG. Question that?
Yes, DIPG is actually a type of brain tumor that involves the brainstem. And again, we've talked a lot about successes in pediatric cancer. Unfortunately, patients with DIPG do not have a good chance of overall survival. Most patients with DIPG die within the first year of diagnosis. However, because patients have been enrolled on clinical trials, we've actually been able to understand the biology of that disease much better. And within the last year, we've implemented new clinical research trials that are aimed at looking at those new agents in this particularly devastating disease.
Now, when you are putting together a treatment plan, it might require surgery, it might require radiation, chemotherapy. How do you decide which of those the child might need?
Really good question. And I think that to answer that, people need to understand that when they come to our center, they're not cared for by Mike Kelly or Mike Burke or a single oncologist. We're part of a team. Yeah. And that team includes nurses, nurse practitioners, physicians assistants in oncology, but also surgeons. It involves radiation oncologists. It involves pathologists that are very important in helping us make it the appropriate diagnosis. And more importantly, or as importantly, in a growing percentage of the case, basic scientists who are helping us understand the biology of certain types of tumors in order to tailor our therapies. But the reality is that not every patient with every type of cancer will see a surgeon or a radiation oncologist. But depending upon the type of cancer that they have and the location that it's in, they may require chemotherapy, they may require surgery, they may require radiation therapy, and they may require all of the above. And
are there alternate therapies or alternate medicines outside of those three that are ever used or considered?
Yeah, there's, one of the things that more and more of our patients are inquiring about are alternative medicines and supplements and the role of diet and supplements in helping control cancer. And the reality is that we are now starting to study those in very rigorous ways and finding that there are supplements that are out there that do benefit certain patients, including pediatric patients with cancer. we have to do that in a way that is known to the treating physician, and in a way that will help minimize any potential side effects due to interactions between chemotherapy and/or supplements.
And looks like we might have some questions from our live audience.
Yeah, so I think we kind of just touched on this one, but does Children's Hospital of Wisconsin offer integrative therapies to assist patients manage their symptoms and side effects from treatments?
Really good question, and the answer is we are in the process of developing a more integrated medicine approach. There are certain components that we offer, and things like massage therapies, things like acupuncture to help control nausea, which is a common side effect, or pain, which is also a common side effect. So we're starting to implement many of these, and we're starting to grow a program and develop a more integrated approach to using alternative medicines and alternative approaches in addition to conventional therapies like surgery and chemotherapy and radiation.
Is there some more questions there?
Yep, we had another one. Gigi asked a little bit more of a specific question. Is there research happening for regeneration to optic nerves due to damage from optic glaucomas, or to a possibility of restoring a vision loss? Is there anything that we can touch on that?
There's actually some very interesting work that's being done in the stem cell field, and looking at recovery from neurologic injuries, and many of those have focused on spinal cord injuries, but optic nerve injuries are also being looked at as well.
Thank you.
Now, I would imagine that the diagnosis of cancer can be pretty devastating for any parent to hear, and when they start to understand the plan or the course of treatment, that's can be a hard thing to understand. And what options should parents pursue, or what factors should they consider if they are thinking about a second opinion?
Really good question. I think that we are a very large center. We offer comprehensive, what I call portfolio of therapy options. Not only the considered standard of care for therapy, but also new therapies, all the new therapies that are out there, or many of the new therapies that are out there. But in situations where patients are diagnosed with very rare cancers, or their cancer has come back, we often encourage our families and patients to seek second opinions, and we'll help direct them to centers that are really able and capable of providing those second opinions.
What do you love most about your job?
What I love most about my job is the kids. I can honestly say that I enjoy taking care of kids, and I enjoy interacting with kids. I really enjoy seeing kids, or taking kids from a very devastating point in their lives and watching them grow up, and watching them grow older, and watching how they do that, and the unique aspects of kids. And it's been very fun and very rewarding. I'm not saying that we cure everybody, and there clearly are losses along the way, and my job as director is to make sure that we minimize those losses, but when they do occur, and when patients die from their disease, we learn from that in order to help prevent that in the future for other patients that come along with the same disease or have the same complication.
Now, you've invested your career in this, and I'm curious, what do you think is the biggest mystery you're trying to solve right now with childhood cancer?
Wow, that's a good question. So the biggest mystery, I think, is really unlocking the genetic causes of cancer, and really understanding how the genetic causes influence or are influenced by environmental factors that we still are trying to figure out. But in general, understanding the genetics and understanding how that can give us clues as to what new therapies will likely be effective in different types of cancers is really fascinating.
Dr. Kelly, thank you so much for taking the time to talk with us today. I really appreciate it. And thank you for joining us during our live broadcast. If you'd like to learn more about our Mac Fund Center or Children's Hospital of Wisconsin, you can visit us online at chw.org. Thank you.